all of you. Myself, Dr. Bharti, Principal, Faculty of Physiotherapy, RPIIMS College, Karnal. So today we will be learning about the sensory tracts. So what are the sensory tracts? Sensory tracts are nothing but the collections of the nerve fibers within the central nervous system which have some specific origin, which have specific course and terminations. In that sensory tracts, we include some terminologies that are fasciculi and lemnisci. What does it mean? Fasciculi means a bundle of nerve fibers and lemnisci means the ribbons that carry the information from one part of the central nervous system to the another part of the central nervous system. So, how we name that tracts? Some tracts are going from up to down and some from down to up. So, they are named according to the origin of the neuron that are arising from the spinal cord, that are over the lower center of the central nervous system, and some are the neurons originates from the cerebral cortex, that are the ascending tracts, that are the higher center of the central nervous system. So, tracts are named after the masses of grey matter that are connected by them. We have a first order neuron and we have a third order neuron. For example, if we are taking that spinothalamic tracts, that means origin, the neurons are originated from the spinal cord and they terminate at the level of cerebral cortex, that is at the thalamus. So we name them spinothalamic tracts. So we'll discuss one by one. So we discuss ascending tract first. We have two main tracts that are the ascending tracts, which are, one of them is spinothalamic tract, which consists of two type of tracts, that are the lateral spinothalamic tract and the anterior spinothalamic tract. And another one is posterior column tract that ascends from posteriorly, originates from posterior aspect of the spinal cord, which includes tracts of the fasciculus gracilis and tracts of the fasciculus cuneatus. Then ascending tract, basically the spinothalamic tract, they conduct impulses from the periphery to brain through the spinal cord. That means the fiber originates from the dorsal root of the spinal cord and they carry information till the cerebral cortex, which is the higher function, higher center of the central nervous system or the brain. So we have three type of sensations: pain and temperature, and then is touch and proprioceptions. So those fibers concerned with the pain and temperature, they carry by the lateral and the spinothalamic tract. The sensations from touch and the proprioception carry sensations by fasciculus gracilis and the cuneatus. So there are three major tracts that carry information. First one is anterolateral, another one is posterior column. So we'll discuss one by lateral spinothalamic tracts. As shown in the diagram, that lateral spinothalamic tract carries impulses from pain and temperature sensations from one side of the body. Now, the first order neuron that originates from the dorsal root ganglia of the spinal cord, and then they move up, that means ascending upwards, they move up towards the medulla oblongata and the part of the midbrain, which are the part of the brainstem. Then they carry sensations to the thalamus, which is the part of the cerebral cortex, and that is responsible, thalamus is the structure which is responsible for the temperature, and here they give information to the in the form of different projections to the sensory homonucleus of the cerebral hemisphere. Now we come to what are the clinical aspect of that lateral spinothalamic tract. If there is any lesion in the spinal cord level, if there is any lesion at the spinal cord level that carry the pain and temperature, they cause bilateral loss of pain and temperature sensation below the level of lesion. Now we come to the another tract, that is anterior spinothalamic tract. They carry sensations of light, touch, pressure and the proprioception from the opposite half of the body. Why we are using the term opposite half of the body? Because the fiber originates laterally, but they decussate or cross over at the level of the midbrain and they give projection to the sensory homonucleus of the left cerebral hemisphere. As shown in the diagram, that fibers of the touch and temperature moves upward towards that cerebral cortex by crossing the medulla oblongata and the midbrain level, which is the part of the brainstem. At that level, the fibers get decussate and move upwards to the opposite side, give the projection to the cerebral hemisphere and perceive the perception in the form of touch, pressure and the proprioceptions. Now, what are the clinical aspects? If there is some lesion at that level, there is a loss of light touch pressure on the opposite half of the body. Why opposite half of the body? Because the fibers get crossover at the level of midbrain. That's why sensation perceived at the opposite half of the body below the level of lesion. Now we come to the tracts of the fasciculus gracilis and the fasciculus cuneatus that occupy the posterior white column of the cord, that means the posterior aspect of the spinal cord, which has nuclei or the fasciculus of gracilis and the cuneatus. Fasciculus gracilis are responsible for the perception of sacrum, lumbar and the lower thoracic level, but the cuneatus that lie laterally, which are responsible for upper thoracic and the cervical lesions. So, how that fibers carry the impulses? The fibers carry impulses in the form of proprioception and the kinesthetic sense from the same side of the body or the ipsilateral side of the body. As shown in the diagram, in the spinal cord, the fibers of the gracilis lie medially and the fibers of the cuneatus lie laterally. That fibers arises from the dorsal root ganglia of the spinal cord, then they move upward in the midbrain, then move in the ventral nuclei of the thalamus. Here the perception of temperature has been occur. Then that level give the projection to the sensor homonucleus of the left cerebral hemisphere and give the proprioception. So if there is any lesion at that level, at any level of that dorsal column, so there is a impairment of the proprioceptive sensibility, loss of sense of tactile discrimination, vibration, passive movement and appreciation of the posture. Patient unable to tell where the part of the limb placed or where the position or the movement of this lower limb, unless he see them but unable to tell the position or the movement. Thank you so much.